Today we will discuss syringomyelia. Syringomyelia is a developmental anomaly in which there is a formation of fluid-filled cavity surrounded by glial cell in the center of a spinal cord. This fluid-filled cavity can arise anywhere in the spinal cord, but the most common site of origination is C8 to T1. You guys can see this diagram. This is a cross-sectional view of a spinal cord, and the structure which is lying at the center of a spinal cord is a fluid-filled cavity which is formed in syringomyelia. This fluid-filled cavity is also called as a syrinx. Due to the formation of this syrinx, there are three neurological findings in syringomyelia. The first one is the dissociative sensory loss in neck, shoulder and arm. By the dissociative sensory loss, we mean that there will be bilateral loss of pain and temperature while the vibration and proprioception will be conserved. The second one is the lower motor neuron sign in upper limb. By the lower motor neuron sign, we mean the muscle atrophy and the loss of reflexes in upper limb. And the third one is the upper motor neuron sign in lower limb. The upper motor neuron sign, we mean weakness, spasticity and the exaggerated reflexes. Now a question arises that how the syrinx cause these neurological abnormality. To understand it, let's look at this diagram. You guys can see that the syrinx is located in the center of a cord. So any fiber which crosses through the center of a cord will be affected. So there is only one fiber which passes through the center of a cord are the spinothalamic fiber which carry the sensation of pain and temperature. Usually they cross through the contralateral site in the center in spinal cord. So when there is a syrinx, the spinothalamic fiber will be disrupted and there will be the loss of bilateral pain and temperature. But there will be the conservation of vibration and proprioception because these fiber passes in the dorsal column and the syrinx is limited to the center of a cord. This is how the syrinx cause a dissociative sensory loss. Now come toward the second neurological abnormality, the lower motor neuron sign in upper limb. How the syrinx cause it? Usually the syrinx is located in the center of a cord, but sometimes it expand and increase in size. When the syrinx is increased to such extent that it involves the anterior horn. When it involves the anterior horn contains the lower motor neuron. The lower motor neuron will be affected and the patient will present with a lower motor neuron sign in upper limb. Because the syrinx is usually located at the level of C8 to T1, so the anterior horn of that area will be affected. So there will be the lower motor neuron sign in upper limb due to the involvement of the anterior horn by the syrinx. Now come toward the third neurological abnormality, the upper motor neuron sign in lower limb. Usually, as we discussed in the previous section, that the syrinx can expand and involve the anterior horn. Sometimes the syrinx expand and involve the corticospinal tract. So when it involves the corticospinal tract, it will produce the upper motor neuron sign in lower limb. It was all about the pathological basis of a neurological finding in syringomyelia. But how the patient of syringomyelia will present clinically? Clinically, the patient of syringomyelia will present during the third and fourth decade of life with the wasting of muscle of hands, forearm and shoulder girdle, along with the loss of pain and temperature sensation. Usually the patient will complain of painless burns and patient will suffer from difficulty in walking. So these three are the diagnostic clue toward the syringomyelia. The most common diagnostic clue to syringomyelia is the loss of pain and temperature sensation, which a patient will complain of the painless burns. It was all about the clinical feature of syringomyelia. Now come toward the diagnosis, that how we will diagnose a case of syringomyelia. Usually the diagnosis is on a clinical ground, but sometimes we can perform investigation such as X-ray. The X-ray will show the congenital anomaly of the foramen and it can show the widening of a cervical canal. Other than this, we can also perform an MRI. The MRI is the investigation of choice for the diagnosis of a syringomyelia. You guys can see the MRI and the MRI is showing the syrinx. After diagnosis, now come toward the treatment of syringomyelia. The first line treatment of syringomyelia is supportive treatment. The patient should perform regular activity, should do physiotherapy and avoid burns, trauma or hot water. Other than this supportive treatment, the patient can also undergo surgical treatment. The surgical treatment of syringomyelia include cervical decompression, the dorsolateral myelotomy and shunt. Cervical decompression, there will be a suboccipital craniectomy at the C1 to C3 level along with laminectomy and the duroplasty. In the dorsolateral myelotomy, in this procedure, the syrinx is drained into the subarachnoid space, and this is usually performed after decompression. And the third one, shunt. In shunt, there are different shunts which we can perform to drain the syrinx, such as the syringoperitoneal shunt, the syringo-subarachnoid shunt and the ventriculoperitoneal shunt. So it was all about the syringomyelia. If there is still any question, you guys can ask and stay tuned for more update.